All right. So before we get started, Priscilla, do you have any questions?
Not at the moment.
Okay. So exam three
Okay.
is going to be 50 questions, right? You have 75 minutes to complete your exam, and I will share my screen. All right. So Maslow's hierarchy of needs. And I know that you've heard about Maslow plenty of times before. Let me just make sure you got that. Okay. And so Maslow's human needs theory states that certain internal, external, physical, psychological needs are common to all people, and they are arranged in the hierarchy. And if they're unmet needs, or if they have unmet needs, right, that will create tension, and is going to motivate that person to react to meet their needs. And then, of course, if their needs are met, they're no longer aware that they have that need, so that is not going to motivate them anymore. Um, got one more coming in. And so, part of it is, the basic needs are going to be those physiologic needs. Good morning, Gretchen. Oxygen,
Good
food,
morning.
water, elimination, safety, sleep, activity, right? Those are going to be your basic needs, basic physiologic needs. And then, of course, safety and security, right? Making sure that they are free from harm, that we are protected, we're protecting our patients. And so the primary areas that, for nursing care are going to be the two basic needs, which are going to be your physiologic and your safety. Then we have Leninger, Madeline Leninger. She developed her cultural care theory, that there are two kinds of care in every culture. We have generic, which are your home remedies, and then professional, which are those that are provided by specially trained professionals. And there's three models or three modes um, that she proposed to guide nursing decisions when providing care. So cultural care, preservation or maintenance, right? Making sure that we're assisting people within other cultures to maintain their care values, that will help them to maintain their health or to restore um, health. And then the cultural care accommodations, just kind of making sure that we, excuse me, me and my voice are having issues. Um, that we are just accommodating, right, some of those cultural care. And then cultural care repattering or restructuring. Leninger, just was really concerned with making sure that we are respecting those cultural differences, in addition to providing the a safe and protective environment. Um, I'm gonna get my throat back on track. Oh, so we already. Um, and then we have PEP law. So PEP law's theory has four um, overlapping phases. Hers is the interpersonal relations theory, and this is just basically the basis for forming a therapeutic relationship with the client. Sorry, I just want to make sure nobody else is joining. Um, and so the four overlapping phases, we have orientation, right? That's where, the client comes in and they are seeking, assistance for whatever, their need is. So we help to recognize the problem, Um, and, it's personal social growth can happen here. During the identification phase, the client understands and will respond to the nurse. Um, and then exploitation is where the client begins to depend on the nurse and then will use the help that is offered, exploring all possibilities. And then during the resolution phase, the dependent behavior is given up as the relationship comes to an end. And this is really important because how the nurse handles this is crucial. Because, if we don't end it, correctly, it could, um, they could have more physical symptoms. So making sure during that establishment of the therapeutic relationship that we are fulfilling all of our roles as a nurse, right? We're a teacher, we're a leader, we're a counselor, we're an advocate, right? And Dorothea Orem, this is probably one of my favorite theorists. But she developed the self-care deficit theory. And within that, there is three sub-theories. So self-care, right? That is, directed towards a safer environment for life, for health, for well-being, right? Ideally, people will learn to respond to, the cues within their body or the environment to maintain personal health. The self care deficit, the person doesn't meet therapeutic self care demands, so they don't recognize or know what to do in regards to their personal health situations. Um, and then the nursing system. And this is where nurses empower the client through their interpersonal relationships to help meet their self care demands, right? So it's more of like a supporting role to the patient to help them meet their needs. And it's really um, she was really concerned with, the growth and development needs as well as the physiologic and the psychosocial needs of the patients, right? So it's all kind of incorporates all steps of the nursing process. And so, just think of, when we have patients and we do our data collection, right? And then we are, identifying those interventions as well as goals for, in that planning process for our patients. Um, let's see. Then we have Rosenstock. Um, Rosenstock, hers is the health belief theory that basically tries to explain why a person will or will not take action to prevent or detect illness. And so with this, um, the perceptions vary. They may have no basis in reality. Um, the beliefs are connected to existing barriers so that like they may see preventative or treatment activity as expensive, as painful, as inconvenient. And so that is one of the reasons why they may not um, take action, when they start to have symptoms, and think about, even the financial barriers. Not everybody has access to healthcare, right? So that could be a reason. It could be expensive. And so, that could be another reason why they aren't seeking healthcare when they start to have, any kind of issues. And then a cue to action is seen as necessary. It's usually, something like pain or something that is going to bring them to seek health care. And so we use this. Um, this theory can be used to promote health, right? So getting those, those yearly physicals, their vaccinations. It could even be wellness classes. Um, and then, we can use it too when we're developing those interventions for our clients, when they are dealing with an issue, whether it's a disease or another health problem. Um, and so that brings us to critical thinking. So tell me what critical thinking is. What do you think what is critical thinking to you? Nobody.
I would say using kind of everything that you've learned in school and applying it critically to like a particular situation. So like knowledge base.
Okay. So it's knowledge base, right? And then using that knowledge, right, to kind of, identify issues, prevent issues from happening, right? So it's questioning with meaning. And that's, primarily what critical thinking is. So, this is, think about just the nursing process, right? When you do your data collection and you're doing, your subjective and your objective data and you're, going through all your systems, um, you're really, you're trying to identify problems, issues, and as well as any potential risks that are involved, right? So maybe they don't have a, right, think about someone who's had maybe a major trauma, major surgery, they're going to be bedridden for a while, right? Maybe they don't have pressure areas, right? But if we know that they're going to be bedridden, then they have that potential. So we want to make sure that when we are doing that data collection, right, that we are collecting the data in an organized way that is identifying any current issues as well as any potential risks. Um, and then, of course, during the planning, right, we're using that knowledge to tailor approaches based on the circumstances, right? So we are going to identify our goals for our patient based off of what the problems, issues, and the risks that we identified during our data collection phase. And then implementation, right? And so this is always, something we're going to really think about. Um, what what interventions can we employ you in taking into consideration their problems and their risks, and then we are going to develop those interventions. They are based on knowledge, they're based on skills, right? Just like you said, everything that you learned in nursing school, right? This is where we're going to start to put it into action. And then, of course, during evaluation, we're looking at, the interventions that we put into play. And, was the patient able to meet the goals? And if not, then we're going to go back, we're going to restructure our goals, right? We're going to change or add interventions. And then, help our clients to achieve those goals. And so some of the things here, some of the scientific principles under your critical thinking, um, is collecting data in an organized way. And so you guys are getting ready to graduate, right? You're in that last term. So, really looking at, how you do the process when you are gathering your information, right? How, perfecting that that assessment, when you're doing your head to toe and you're doing your interviews with your patients, you're verifying data, and then you're arranging the data, right? So you're trending it. Lenny, looking for any gaps in information. And so this is where you can always go back and clarify. Um, and then you are going to analyze it and then test it. So when you're testing it, right, is the data purposeful? Is it outcome or goal oriented? Then we have cognitive thinking. So cognitive thinking, we have different levels. We have our our knowledge, right? That is your recall. So when we think of cognitive, right, it's the knowledge that you have learned, the knowledge that you have. Um, and then comprehension is understanding. So this is where you're taking the knowledge that you have and how well do you understand it so that when you go to the next phase, which is application, sorry. Right, that is when we can start to apply the knowledge that we have gained and understand. And then analysis is breaking it down into different parts. And so with analysis, you're breaking down the complex information into basic parts. And this is how you can organize and prioritize. So, which concepts are going to be more important, like, when you're looking at your patient, what is more urgent, and then we kind of work down from there. And so trying to think of like a good example, oxygenation needs, your pain needs, right, which are going to be the most important. And so knowledge would be something basic like that, you may have memorized along the way in nursing school. So like your normal potassium levels is 3.5 to 5 milliequivalents per liter, right? Um, your comprehension. What does it mean if the patient is hypo or hyperkalemic, right? And we know that potassium is one of those electrolytes that we have to keep really, really good, right, within those levels because it can have some devastating effects if we don't. And then your application is, what do you do with this information, right? What do I do if my patient has high potassium levels or low potassium levels? And then analysis would be, how does what I do impact the client overall, right? So does that make sense? Are y'all with me?
Yes.
Okay.
That's
All right, so formulating the clinical question. And so it's formulated in an objective and concise manner. And we are going to use professional resources, um, the latest, the most relevant resource. And so with that, too, you have a variety of resources that are available to you, through the American Nurses Association, through AHRQ, through the CDC, right? As well as, some of the other professional magazine or professional journals and things like that. So we want to make sure that we are using those professional resources to look at, whatever the clinical situation is. And then an expert or a panel of experts will conduct a systematic review. And they're going to take all the, current information that is out there, that they are looking at, and then they are going to write a summary of the selected studies. So I don't know, take a study, let's say, give me trying to think of a good one. Just look at, we'll use vaping as an example, okay? The effects of vaping on somebody. So maybe there's, somebody who wants to, look at, the effects of vaping. So you're going to take a selection of articles. Maybe there's 200 research articles on the effects of vaping. So you're going to select a group of articles. And then you're going to take those articles and you're going to write a summary. And that's part of this process. And then from that, we establish guidelines. Um, and then the information, the gathered evidence is going to then be combined with your clinical experience, as well as the client's preferences and values for use in a specific situation. And so that's just kind of gathering a different, a bunch of information to provide, the best. And I use vaping just because that's kind of what came into my mind, but it could be, any situation that you are looking to help your client with, with any kind of issue. Evidence-based practice. Everybody's heard of evidence-based practice, right? It is kind of, the reasons behind what we do and how we do it, right? That's the biggest part. Why is washing your hands so important? That kind of information. And we know that, the prevention of the spread of infection, but that's all based off of evidence-based practice. And so the elements of evidence-based practice are your best practices, which is your best research evidence, your clinical experience, and then, of course, client preferences. And so that brings, that brings us to research. And so research, we have different types of research. We have quantitative research, which is an objective study that uses variables for measurement. And it's a randomized controlled trial, which is the recommended type of quantitative research. Um, and, with nursing research, again, it all boils down to kind of why we do what we do. It provides the evidence, to support the quality as well as cost effectiveness. It also, works to provide knowledge, for clinical practice, for nursing education, for, how we deliver our nursing care. And so, with that quantitative research, it's collecting, like I said, it's an objective study that we use variables. It may be that we're trying to look at the effectiveness of a new medication for a disease process. And, we'll take two groups of people and say we'll give one group, we'll give them, the new medication, and then the other group will get, the current medication, right? And we're kind of compare to see which group does better. Is the new medication better, or is the old treatment, or is the old medication better? And that will help us. Does that make sense? And so
Yes.
we're just gonna compare, right? We're gonna measure one group versus the other. Whoops. With qualitative research, this is more of a subjective study. So we are going to gather our data usually by interviews or with direct observation. And direct observation, right, is what you observe as the client responds. Um, and so, we will identify themes during our qualitative research. And it could be just a narrative description, right, of what the patient or the client tells us. Um, and this could be a variety of things. We think of qualitative data, think of patients that have chronic pain, um, you know, um, and so you're just going to get a narrative like, what is their, experience, living with that chronic pain. Another way we can do this is through surveys. And I'm sure, you guys are in nursing school, so you got surveys, right, at the end of the term, at the end of the program. Um, and so that's another way that we can obtain information for a qualitative research. It's just gathering data, analyzing the data, and, it helps them to, discover new theories regarding a particular thing. So if it's like living, somebody that is living with pain, right? And we have, 150 people and we get 150 people's input as to how they're dealing with their pain, right? Then we can use that information in order to establish, maybe some new interventions or different types of interventions based off of what we find. And then we go into our nursing roles. And so with that, you have your LPN charge role, is generally as a first line manager within a long-term care setting. And so again, under the supervision of the RN, you will need to, prioritize your client care based off of what their needs are. And then as well as to be responsible for delegating care to your unassisted licensed personnel. And then, of course, making sure that we are following up to make sure that is done, because with delegation, right, you as the nurse are going to be overall responsible, right, for the care that is provided under that delegation. So, with the spirit of inquiry, what is the spirit of inquiry? What does that mean?
Don't we raise questions? Like, I guess ask questions because we're inquiring about something.
Absolutely right. Having that questioning attitude, right? Which is super important in nursing, right? Raise questions, challenge tradition. So we talked about this, right, in class. Um, if there's, a certain, there's the way that we've always done it, right? And so what if, you're studying or, you're reading an article about something, right? Challenge it. You can, say, hey, I read this research article in this journal, and they suggested, or they're saying that this process should be done this way. They have more improved, better outcomes, right? So you may, be challenging, do what, look at the research, challenge those existing practices, and bring the evidence with you. And this is important at all levels of nursing, CNA, LPN, RN, right? If you're doing research and research is showing that there's a better process or to improve patient outcomes, bring that information forward. Most levels of, or most hospital systems, even in long-term care, right, if there is evidence to support a better way, then they will look into it and look at potentially changing it, right? But it is always good to have a questioning attitude, right, to try to find better ways for us to take care of our patients. And even being creative, right? And especially in long-term care, we look at things like there's, the standard ways to, prevent pressure ulcers, like turning and repositioning and good hygiene and good nutrition, right? But what are maybe some of, the more, creative ways to try, or even with, getting people to eat, preventing falls, right? So there's standard ways that we can do that, but what are some more creative ways that we can use to prevent some of these negative outcomes? Um, and a lot of times it's going to be based off of the individual, right? So, what works for Mrs. Jones may not work for Mrs. Smith, right? But trying to identify those different ways to keep people safe, right? That's part of what that's part of our job as nurses. And then we get into our healthcare agencies. And so this is what we talked about last week, right? And the different types of healthcare facilities. So the pub official, which is your government, the unofficial, right, and those private industries. So when we look at the government healthcare agencies, those are supported by tax money. They offer disease prevention as well as health promotion. They will provide direct service health care. And they are accountable to us as taxpayers as well as the government. And of course, depending on where they are, or the area that they're in, there's going to be mandated as well as non-mandated programs. And so with those government agencies, right, there's local agencies, there's county, there's also state, right? So your local is going to be like your health department, and that is funded by local money. So as well, they get subsidies from the state and federal levels of government. They will carry out state laws concerning community health, which are mandated. And then some of their not mandated programs, like which would be like your health promotion programs, and then they collaborate with other government agencies, respond to community health issues. Like if there's an outbreak of a contagious disease, right, then they are going to respond. At the state level, each state has a health department that is funded by state money. In some cases, too, they will receive money from the federal government. And then at the federal or the national level, that is the U.S. Department of Health and Human Services. Um, and the person the person that runs it is what do you call it? Is appointed by the President of the United States. And they'll, be the ones to advise the president in any health matters. And it is federally funded by federal taxes. And so under the Department of Health and Human Services, there's 11 operating divisions, and then 8 agencies in the U.S. Public Health Services. So your FDA, which is the Food and Drug Administration, they're the ones that make sure like our food, our medications, any biologic products, medical devices, electronic products, right? They're all safe and effective. Your Centers for Disease Control, they provide the leadership in health prevention and promotion programs. They also respond to public health emergencies. Also a valuable resource, right, for information about current trends in health. Um, Lots of good research on there. The National Institutes of Health, they are the ones that fund biomedical research in their own laboratories. They also in universities, trying to think, universities, hospitals, even in some private research places, private industry. They also train new researchers. They, collect, share medical knowledge. Um, And then we have our public or our non-official public healthcare agency. This is supported by contributions. It's a private service that does research and education. They are going to be accountable to their supporters or their board of directors. And the programs are determined by supporter interest. And then we have our private healthcare agencies. And so the service must be paid for. And so there's a variety of, different types of private healthcare agencies that are out there. They include both for-profit and nonprofit organizations. With your private healthcare agencies, they are accountable to their owners. And the programs offered are based off of the goals of the organization. And they'll work to cure illness. They also will provide some sort of wellness as well as disease prevention services. Your teaching and research hospitals. We talked about these as well. These could be either community or they can be federal government hospitals. So like you think of like your VA hospitals, some of your military hospitals as well, right? They are a lot of times teaching hospitals, other like I know Centera up in Norfolk, right? It's a teaching hospital. Um, and so they are training sites for healthcare providers, nurses, other health professionals. They will still, treat clients with serious, unusual conditions. They also will do research, develop treatments for disease conditions, health promotion, also look at developing strategies to deliver low cost, high quality care. They will do clinical trials as well. So like EVMS in Norfolk, right? They're always conducting clinical trials, just, depending on what it is. Um, they're almost always affiliated with a medical school. And with this too, they have, access to really highly skilled practitioners. Your nonprofit or your your nonprofit community hospitals, they are operated by the community as well as religious organizations. They depend on gifts, right, and donations to supplement their revenue. They'll provide short-term inpatient care for acute illnesses and injuries. Um, the responsibility will rest here with the board of trustees, which is usually like from the community's business and professional people who generally serve without pay. But they will have a paid administrator that does operate the hospital. And then we have home health. So home health is usually directed by a registered nurse. There's different types of home health as well. There's public and nonprofit. They, could be freestanding, they could be hospital based. It really just kind of depends. The focus here with home health, right, is that relationship centered care, right? The family, the client's environment. The goal for home health is to promote, maintain, or restore health, right? Try to minimize the effects of illness or disability. And so in order to qualified for home health, they must be homebound, and they also must have a skilled need. So what are some examples of skilled needs?
Is it like help with like their ADLs? Mm,
So in some cases, it can be based of what their diagnosis is. Um, is skilled nursing primarily is what we're looking at, giving injections, maybe maintaining an IV, wound care. It also could be like they need physical therapy or occupational therapy, speech therapy, um, maybe nutritional, those kinds of things. So they have to be homebound, that they have to have a skilled need in order to qualify for home health. Um, and so this is your skilled nursing. So it's medically necessary care to improve health or maintain or slow decompensation. So again, home health can be what's the word? An alternative, right? To go, instead of going to maybe a skilled care facility or rehab, if they haven't identified skilled care, then we can send them home with home health, as long as they have a skilled need. So, any type of major surgery, giving IV medications, severe infections, other health issues, right? Post-stroke care would be one, right? That's where your physical, your occupational, your speech therapy, would come into play. So again, the home health is usually, it's going to be guided by an RN. But the LPNs can provide, nursing services under that supervision of the RN. So some of the primary duties of an LPN, right, reinforce the teaching. So the RN is going to set the teaching plan, provide the initial education, right? And then the LPN can come in and reinforce that teaching, as well as supervising, preparing medications for self-administration. You can give injections, check glucose levels, assist in creating that health or that safe environment, right? So we talked about that in class, like how do we, promote that safe environment? We talked about proper lighting, removing obstacles, throw rugs, right? Looking for, electrical cords that could potentially be an issue. Um, if they're using oxygen, right, that they understand there's no smoking in the home, right? So there's a variety of different things that we can do to help create that safe environment within the home. And then of course treatments, right? So ostomy care, wound care, bowel bladder training, oxygen, respiratory care, right? So there's a variety of different, things that we can do for home, right? So I talked about this in class, right? The amount of services now that we can provide in the home has grown tremendously, right? And it has improved morbidity and mortality. People generally are going to be more comfortable in their own home, right? So if we can provide the services in their home, that does in most cases will provide for better outcomes. And then we have our excuse me, our hospice and our palliative care. Um, Hospice, the goal is to maintain comfort as death approaches, right? And so one of the biggest parts of hospice is death with dignity, right? So maintaining that comfort. Hospice can be provided in numerous settings. It can be provided in the hospital. It can be provided in a long-term care facility. It can be provided at home. Or in some cases, there is even like hospice houses or hospice homes that they can go to. Um, they have to have a terminal diagnosis. usually within they'll usually have 6 months or less to be eligible for hospice. And we will provide, especially, we will provide pain and symptom management. Palliative care is comfort care. It is very similar to hospice care. But in order to receive palliative care, they do not have to be terminal. We can do life-saving treatments while giving palliative care. Whereas with hospice, we're not really using those life-saving treatments anymore. And so that's why they don't have to be terminal in order to receive palliative care. So this can be offered at any stage in the disease process. And then we have wellness centers. So wellness centers obviously are going to promote wellness promotion. And so with these, there's a variety of services that are available. They can do nutritional counseling. They may have exercise programs, stress reduction, weight control. And generally it's private sector that is going to have these wellness centers, right? So these are things like Weight Watchers is a big one. It could be, things like, my gosh, stress control, parenting classes, smoking cessation classes. And so again, LPNs can work with the RNs in providing some of these services. Community health services. The community health services are best for those that are in need of education. So, different groups. They're good for screening and early disease detection, as well as prevention. And so remember back in community, when you talked about the community health nurse, right? And all the different roles of community health. You guys are, community health workers deal with many different people and groups. They work as advocates, caregivers, case finders, health planners, health nurses, your school nurses. It could be part of an outpatient clinic service, or it can be a service that is directed to an HMO, or even freestanding private services. Oops. Talked about adult daycare centers. And so adult daycare centers provide services for those who need supervision, whether it's because of a physical or safety need, but they're not a candidate to go into a long-term care facility. So maybe, it's somebody that's living with a family member. That family member is available in the evening, right? And on weekends, but they don't want to leave their loved one home alone during the day. And so what's nice about the adult daycare centers is, they can still live at home, but they can go somewhere during the day. They are able to socialize, right? They get that stimulation that they need. They also may get some assistance with their ADLs. They're in a nice, safe environment. In most cases, your adult daycare centers will offer transportation, meals, therapeutic activities, right? In some cases, also, they'll offer rehab services. Some of these daycare centers, too, will have providers available to them that can, address any concerns while the patients are there, because they're there, some cases they're there every day. In some maybe, only a few days a week. It really just kind of depends. And then your care facilities. So we have independent living, residential care, assisted living, long-term care, independent living apartments. They are not licensed, they're not regulated for healthcare delivery. They, just are living with other people their age, right? So you're like um older adult living like apartment complexes, that kind of thing. And so they're, around people their own age for socialization. Um, they will have some planned activities that are provided with the individual or independent living. It really just depends, but they can, age in place. Um, your residential care home, um, those are a little bit different. They are going to provide housekeeping as well as personal care. Generally, this is a much smaller environment. Um, they're usually like your group homes, they're living within a house. So it's usually a much smaller population within there. They may have only 4 people living in that home or, more depending on the size of the home. And they're offered assistance with their ADLs. Um, they will self-administer their medication, but they'll get assistance with preparation of meals, diets, transportation, um, and they have to be licensed as a group home. Assisted living, right? So assisted living is a little bit different. This is a home with services. It's, still maintains their privacy as well as their choice. They are, in like in apartments and have basic needs in there. They goal is to try to live as independently as possible, but may still need some help with their ADLs. Um, they're usually handicapped, accessible as well. And so they do kind of get help with daily routines, like maybe getting up in the morning, getting dressed, that kind of thing. But the care generally isn't going to be 24-hour basic care. But they can get help with bathing and dressing and health maintenance. In some cases too, even case manage or care management, and skilled nursing services based off of, what their needs are. And then of course we have our long-term care facilities, that provide a range of medical services, whether it's due to a disability or, a chronic care need. Um, so a lot of your patients or a lot of your residents in long-term care, they will have some sort of a chronic disease or disability. Um, and the focus for long-term care is promoting independence as well as maintain function, and support autonomy. And so it just really kind of depends on what the need of the patient is. And it is, most long-term care, there's some reimbursement for Medicare, Medicaid, Veterans Health. The Affordable Care Act, which is, we talked about the financing of healthcare, in class. Um, and so the Affordable Care Act, was signed into law, right? And it was to, enhance the access and the affordability, of healthcare, to those, especially those that are in financial need. Um, and the goal was to, right, increase or decrease the number of uninsured patients or uninsured people in the United States. Um, whether for reasons of being underemployed, underinsured, or uninsured. Um, And so there's lots of different, lots of provisions under the Care Act. My gosh. But it, like I said, it has decreased the number of uninsured in the United States. It also eliminated, um, lifetime coverage limits, right? It also made sure that those pre-existing conditions were covered, which was a big issue for a lot of people prior to the Affordable Care Act. People weren't always able to get coverage because of or they had to wait for coverage because of their pre-existing condition. So that was something that was a big part of the Affordable Care Act. Um, it also reduced prescription drug costs for Medicare beneficiaries, which if ever notice the cost of medications, they can be quite costly. Health insurance terms, premiums, right? That's your monthly fee. So, whether it's through your employer, whether it's through the Affordable Care Act, the premium is the monthly fee that you have to pay for your health insurance coverage, right? And so some employers will cover a certain part of that fee, and then the person has to, the person has to cover the other part. The deductible is the yearly amount that you have to pay out of pocket for services before the health insurance policy will begin to pay, right? And so when we're choosing our health insurance or we are, working with clients to get health insurance, right? These are two things that we really want to look at, right? We want to look at how much it's going to cost them every month and then how much out of pocket it's going to cost them to meet that deductible before the insurance will kick in. Your copay, that's how much you pay at the time of a visit. Um, your prescriptions, going into the hospital. Usually these are going to be a set fee. So you'll see like maybe a doctor's office visit is a $25 copay, maybe a specialist visit, a $35 copay, and then, hospital visit, whatever, that could be. So that's how much that the person has to pay out of pocket when they just to go see a provider. And then the co-insurance, once that deductible is met, that's the percentage of the total bill the insured person must pay. Um, so let's say you um, go to the doctor and let's just say it's $150, and the person, maybe the insurance will pay like 120 of it, right? And so the remaining 30 would be the co-insurance, right? That the client has to pay out of pocket. With public health insurance, this is your veterans health insurance, your Medicare and your Medicaid. Veterans Health Administration, right, meets the needs of our veterans. There's hospitals, there's outpatient clinics, there's nursing homes, there's domiciliaries. All of those are part of the Veterans Health Administration. Medicare was established in 1965 to the Social Security Act. It is a federally sponsored program and public health insurance plan for those over the age of 65 and their spouses who have paid in for at least 10 years. Medicare is also available for some younger people with disabilities and clients or patients that have end-stage renal disease. Um, Nobody can be denied Medicare based off of past medical history. Um, Medicaid is a little bit different. Medicaid was also added to the Social Security Act in 1965, and this provides medical assistance for eligible families and those with low incomes and resources. It is jointly funded. So it's jointly funded by the federal government as well as the state government. The federal government establishes the, basic broad like national guidelines. And then each state will establish its own program services as well as requirements. including eligibility. Um, I didn't go through the different parts. So Medicare Part A, Medicare Part A is your hospital insurance. So it'll cover inpatient hospital stays, skilled nursing facilities, hospice care, some home health care. B is your medical insurance. So that's going to, when you go to the doctor for a checkup, it'll cover the healthcare provider services, outpatient care, medical supplies, your preventative services. Part C is your Medicare Advantage plans. Those are offered by private contracts or private companies that contract with Medicare. This can be it could be a HMO, it can be a PPO, fee for service. It also provides prescription drug coverage. And then Part D is your prescription drug coverage. And so it is offered by insurance companies and other private companies that are approved by Medicare. And it helps to provide prescription drug coverage, brand name medications. So here's some of the other things that Part B will cover. So you talked about the physician's visits, outpatient hospital services, including your ER visits, your lab, your diagnostic tests, ambulance transport, your durable medical equipment, obviously the kidney supplies and services for those that have the end-stage kidney disease, some diabetic supplies, some of the skilled care nursing services like physical, occupational, and speech therapy. Part B does not pay for most prescription drugs, routine physicals, or services not related to treatment of illness or injury, dental care, dentures, cosmetic surgeries, routine foot care, hearing aids, routine eye exams, or glasses. So we talked about those. Talked about who's eligible for Medicaid. And then we have our children's health insurance program. This is another really good program for kids. It is a program under Medicaid. And it is for your low cost health insurance for kids up to age 19. They do still have to meet the, financial and other eligibility requirements. Um, and then we have our uninsured population. So even though, we have made strides in increasing the number of people that have access to insurance, we still have a high number of those that don't have health insurance. So some of those characteristics, right? They lack access to health care, which, prevents them from receiving preventive care. It also may prevent them from seeking a treatment when they do develop a health issue. They may use the emergency rooms almost like a primary care. Um, they often will seek treatment later in the later stages of illness, right? That not only is that going to cost more, it could definitely be, more devastating. They generally are either unemployed or they have a low income, so they may be underemployed, right? Not be able to afford to pay for the license or for insurance. Um, or maybe their employer doesn't offer a health plan or it is too costly. And so when we talked about that, when we talked about health insurance, right? Um, I think it's, what is it? Employers that have 50 or more employees are required to offer some sort of health insurance plan, and those that have less than 50 are not. But they do get subsidies if they do. But what's interesting too is the employer is the one that's ultimately going to choose the health plan. And so depending on the health plan that they choose, is going to determine the cost. Some employers will pay a large part of that premium, while others will not. So, even if your employer does offer health insurance plan for its employees, it could still be extremely expensive. And think about having to pay for it out of your paychecks, right? And then worry about, your mortgage, putting food on the table, your car payments, your car insurance, and just basic living. So that could be part of the issue with that as well. The prospective payment system, that's a system of reimbursement that pays a predetermined fixed amount for a service regardless of the actual service provided, right? So the payment is based off of that DRG, which is what we talked about in class. So, if they're admitted for a urinary tract infection, right, then they're going to get a specific amount of money, right, to pay. The insurance is going to pay a specific amount of money, right, for that hospital stay, regardless of, if they required a little more care or a little less care, they're going to get that set fee. The government announces to the hospital in advance what it will pay for healthcare services. So they are going to know that, what the reimbursement is for whatever the injury, the illness, whatever the reason for the hospitalization is. And one of the biggest things it does do is provides a financial incentive for hospitals to control their input costs as well as their resource use. So again, the DRGs, those are categories for illnesses, and the fee that is provided or the fee is based off of those categories. And it's just how the government determines payment. But it is a guaranteed reimbursement. So again, if they can cut the cost for, whether it's some supplies, this is what we talked about, like making sure that we are charging appropriately, that we're not bringing extra supplies into the room that, won't be able to be used. Right. And so it's kind of, cost saving. So if they use less resources, right, then there's going to be a profit based off of, their reimbursement. If they go over that, of extra supplies or, wasteful needs or things like that, right, then they're going to end up losing money based off of that one admission. So how do you, help to improve healthcare? Participate in continuous quality improvement. Follow the aims of the IOM for improving quality in care. Continue competency and skills, continuing education, your certifications. Remember, as LPNs, there are certifications that are open and available to you. And when we look at avoidable events, your never event is a medical error clear to identify and prevent, but the consequences can be serious to a patient's health. And so, this is the goal, is to try to prevent the never events from occurring. Can one of y'all give me an example of a never event?
I'm sorry, Professor. Can you repeat your question?
What's a never event?
Isn't that when we try to identify and prevent something, but it doesn't actually like we don't prevent it. Like it hasn't been prevented. So
Something
we,
happens.
yeah, but something happened. So we didn't like intend for it to happen, but it happened.
Okay. So a never event could be a hospital acquired infection, right? So think of like your catheter associated UTIs, your central line infections, your ventilator assisted pneumonia. It could be injuries from a fall. You had somebody fall out of bed, broke a hip, hit their head, right? Those are never events. Hospitals will not receive reimbursement for never events. And so this is why we look at those preventive, right? What are they at risk for when they come in, right? So, putting your fall risk armbands in when they're on admission, we've identified that they are a fall risk, right? So if you have a patient in your care and they do develop a hospital acquired infection or a injury from a fall or any other potential issue, then the hospital is not going to receive a reimbursement for that never event. They will end up eating the cost for the treatment of that event. So this is why we focus on prevention. With sentinel events, it is an event that starts as a never event but leads to a patient's death, permanent harm, or even several temporary harms. So this is something that um, we also have to pay attention to and try to prevent. So if they, think of trying to think of a good one. Say with that never event, somebody develops a central line infection, okay? And then, maybe a completely go septic and they end up passing away. That would be a sentinel event. Um, or the patient that falls out of bed and hits their head and they have a brain bleed, which leads to permanent damage. So that is why we really look to try to prevent. That's where your safety and all those wonderful interventions that you're going to put into play are super important. The national patient safety goals. So national patient safety goals are there to basically assist this. They are set by Joint Commission. And so with the state national patient safety goals, there is goals at every level of healthcare, from birth to death, whether you're in a hospital, in a long-term care setting, home health, whatever the setting is, that there's a variety of goals available or goals that are listed. So long-term care, national patient safety goals, improve the accuracy of resident identification. So if you've been in a long-term care facility, it's a little bit different than being in a hospital setting, right? They may have an armband on, they may not. One thing, especially if they're fidgety, or, they don't like it, they will eventually try to get it off. So improving the accuracy of resident identification. So with long-term care, a lot of times in their EMR, they have updated it now where they'll have the resident's picture on the MAR or in the patient chart, so that you can accurately identify that resident. Improve the safety of using medications is another one, reducing the risk of healthcare associated infections, reducing the risk of resident harm resulting from falls, as well as, your pressure areas, preventing pressure areas. For hospitals, improving the accuracy of client identification as well. So we always use those two patient identifiers. It could be name, it could be date of birth, or name and date of birth. It could be their medical record number, their phone number. There's a variety of different methods for patient identification, but mostly we're going to use name and date of birth. Also improving the effectiveness of communication among caregivers, improving the safety of medications, reduce harm with alarms, harm associated with clinical alarm systems, reducing the risk of healthcare associated infections, identifying safety risks, and universal protocol for preventing the wrong site, wrong procedure, wrong person surgery. Alliances can be beneficial. So this goes back to, building those relationships with team members and other members of the healthcare team, the interdisciplinary team, to help to improve client safety as well as develop quality improvement projects. And we talked about networking, right? Networking is also very beneficial, as you're looking to, um, go out into the workforce, right? Um, it helps you to identify the benefits of the organization. Um, helps with problem solving, building a team, um, participating in committees is really an interesting part of healthcare as well. There's a variety of community or committees depending on where you are working. Talked about the quality improvement. There may be other committees that are available to you. It not only helps you to network and kind of get to meet other people within the organization. But it also helps with, trending patient issues, building solutions. And then your resume. And so this is also part of this. So basic resume, 2 pages minimum or maximum. 1 page is preferred. Make sure that you're using quality bound paper, use white or off-white. You don't want to use any like really bright papers, any, designs or textures. You're using a cover letter, make sure that your cover letter and your resume are on, the same, the envelope is the same as well. Always use Arial or Times New Roman fonts. Anywhere between 10 and 14 is preferred. You don't want to have it really tiny. You also don't want to have it really big. You want to kind of have it average. Um, you don't need to underline italics. You don't need to add any graphics. Use spell check. Spell check is super important. And then, of course, make sure that you're proofreading when you're writing your resume. And I always suggest having somebody else proofread it, right? Because we're the ones writing it. And so, it makes sense to us. Having somebody else proofread it, right, definitely is helpful. Make sure you balance space. So you want to have it like as uncluttered. You want to make that resume as easy to read as possible. Bulletin styles are good. Most employers are not going to sit there and read the resume. If you like, big bulk paragraphs under your experience, try to bullet them with the highlights of what you did at your in your previous positions. And emphasize your strengths. Whether you have a long history or a limited work history, right? Keywords, use those, emphasize your strengths because that is what's going to draw that employer to your resume. Cover letters are important as well. That emphasizes both your academic and clinical achievements. It's a nice little brief overview of what you have accomplished so far and what you are looking for. After the interview, I'm sorry, always do a thank you letter, whether it's a handwritten card that you drop in the mail or even an email, just to kind of say thank you. You want to include some important, specific points from the interview, like, good afternoon, Mrs. Jones. Thank you for taking the time to meet with me today. I really enjoyed our conversation. Um, whatever, maybe there were some things in in the discussion about the organization or the job that really stuck out to you. You want to highlight those. Um, and then, mention when you will potentially follow up. Um, and just, thank you for your time. Those things, believe it or not, really do stand out to the employers that you took the time, right, to recognize that, recognize their time in meeting with you. It also helps to confirm your interest in a position. Again, here to make sure you're using proper grammar, there's no spelling errors, and that you are using a professional letter format when you are writing your thank you letter. All right, any questions?
No.
No.
Are you sure? All right. I know I went over a little bit. I apologize, but thanks for hanging in there with me.
Thank you for your time.
Absolutely. You guys have a great day.
Thank you.
You're welcome. Bye.